Good afternoon, everybody. Thank you very much for coming to the session, Translational Research in High Myopia. I'll be moderating this session with Professor Min He and Professor Raja Narayanan, if I pronounce correctly. Yeah. So let's start the session. The first speaker is Professor Min He. He will talk about development of a full eye OCT system for characterizing ocular shape and structure changes in high myopia.
I just would like to say thank you very much for Kyoko invite me come over to speak in the high myopia section. Today, I'm going to briefly share with you an idea to develop a whole eye system, in particular in the context of high myopia. This is conflict of interest. In particular, the last one is a file patent that relevant to the technology I'm going to mention. So I start from our high myopia registry study. So this is a 10-year study. We initiate in 2012, and now we already finished the final visit, 10 years visit. High myopia registry. We enroll this 7 to 70 years old patient, sphere only minus 6 diopters or greater. And one of the experiments we work on this particular cohort is we invite this high myopia patient, high myopia participants to receive MRI scan. So this is a paper we published a couple years, like 7, 8 years ago. It demonstrates that actually the ocular shape among the high myopia patients, first of all, the ocular shape is really associated with we call it the pathology myopia grading. So shape is important, that's all we know. So the idea is like having my MRI scan done is very painful, it's expensive. It takes a long time, like 30 minutes, 40 minutes to complete. So the first question is we ask is whether we are able to convert a 2D, two-dimensional, like 2D fundus photo to a 3D MRI photo, MRI ocular shape. So the second question is, can we predict the ocular shape change over time, in particular in a high myopia patient? So this from image to image translation, or the GAN technology, generative AI, we have done some experiment before. So this is one of the experiment we demonstrate that we can convert or translate a full color fundus photo to fluorescing. So as you can see from these images, this is diabetic patient, obviously. In the fake or generative late phase FFA, you can see this neovascularization leaking. So this is very consistent with the real FFA. So that study demonstrates that converting using the GAN technology, generative AI, you are absolutely able to convert a full color fundus photo to a fluorescing images. And then we are able to observe very similar pattern on the ischemia in the retina, and also neovascularization leaking, and also the microaneurysm changes as well. So the question is, are we able to convert directly GAN technology, generative AI, to convert a 2D full color fundus photo to ocular shape, MRI 3D ocular shape? The answer is no. This is not possible. But then it might be possible if you add more information, we call it multi-modality data. Like, for example, the metadata. If you tell the AI what is the axial length or what is the spherical equivalent, combining the fundus photo with the metadata, we might be able to generate MRI ocular shape image. So this is how we develop this segment anything mode that you can easily segment the eyeball from the MRI scan and convert it to a low resolution 3D images. So I'm not going to go through the technical detail. But then again, we need two input. One is the fundus, one is a fundus photo. Second is a metadata. We combine these two into the model, and then we develop a technology that can automatically segment the MRI ocular eyeball from the MRI scan, and then this will generate a 3D view, 3D eye ocular shape image. So and then we use this two input to generate a 3D image, 3D ocular image, compare with the gold standard. So we have a GAN technology. So we need to treat, or CHEAT, treat the AI until AI cannot differentiate the generative 3D image and this is a real or fake. I mean, generated or real 3D images. Then we establish the neural network. So with this technology, we demonstrate that using this a spherical descriptor as a parameters to assess the accuracy of on the generative ocular 3D images. As you can see from here, we can put patients into three categories. One is no staphylinoma, no ocular shape changes at all, eye myopia, like a round shape. And then you can see this this is the gray, the dark light color one is the real one. This is ground truth, and this is the synthetic, like generative one. You see this; they are very similar. And then, but then there's also another category is with staphylinoma affect the macular region or posterior pole. Then we also observe from different view. This is from the, I think it's from the this different view on the 3D image. You see they are very similar to each other. The real one and the synthetic one. And this is the more severe staphylinoma group. And then again, they're very similar. But then we also look at compare this is called chamfer distance. Chamfer distance is a parameters that indicate how close is this two 3D they call it two 3D point set. 3D there's a point set. So generative one and the real one. So with the chamfer distance, we demonstrate actually quantitatively the generative 3D image and the real 3D image, they are very similar. And then we also develop a technology that can simulate what when we change the metadata. For example, we change the metadata, the axial length, or the diopters from -5 to -10. What is going to change? So this will be able to simulate if no treatment, when the patients have a progression on the high myopia, what the ocular shape looks like. So this is we call it counterfactual generation. So we can simulate when the degree of myopia increase, how this might change the ocular shape over time. So this is a good way to scare your patient. If you don't treat if you don't ever receive the treatment, so your ocular shape will become very terribly look. So then we also perform. We look forward to collaborate with you, for example, to validate this model. The model is like you only need to tell the model fundus photo and also the axial length equivalent, and then we will be able to generate the ocular shape for you. So then we call it fundus to globe. And also there's another. We're also working on a technology that can use fundus photo to generate fundus OCT images. So this is fundus to OCT generation. So the question is, are we able to combine the ocular shape, MRI ocular shape, and also the OCT scan? Like for example, and then first of all, we develop a high resolution technology, a methodology that you can collect a high resolution T1 MRI image. You can see the T1 image on the highly myopic eye can be, now you can see the MRI, the resolution is much higher than ever before. So the idea is how can we combine the ultra wide OCT images and using the MRI scan as a ground truth to train the model, develop a whole eye, like a whole eye OCT like this. You can see the schizus and the ocular shape. This is the same patient. The ocular shape on the posterior segment is very similar to the MRI scan, and also we can demonstrate all these OCT histology changes on the eyeball as well. So at the moment we can do half of it, and later on I will show you the whole eye, OCT, whole eye OCT data. So and then in conclusion, when you compare, the MRI scan is very expensive, take a long time to complete, and then it's just only allow you to do static assessment, and it need to be in the MRI clinic. But then with our funders to globe, very cheap, and less than 3 minutes, and also it can simulate what you're going to look like, the ocular shape, and then now we are able to also combine this ocular shape with the OCT data. You can see how eyeball, the whole eyeball will look like in the future. So we are looking for researchers to collaborate on this particular project, and then in Hong Kong Polytechnic University, we developed this RCSV as a research center, dedicating for new solution and product. Every single of our researcher, fellow, they're working on different products and solutions. So you're welcome to collaborate with us. Thank you so much.
Min, a great talk with stunning images. Can we have some questions? Yes. Are there any questions, Tomo?
Thank you so much. So this is a wonderful presentation. I also have the study about the 3D MRI. So I have one big question. So the 3D MRI image is the external information, and the color from this photo is the internal information.
Correct.
And the OCT is the midst information, I think. So I'm not familiar with the AI model. So can you do the, your model is a mix of the external and internal information, but can you do the mix of these three information to the one? So I mean, if it is possible, we can get the comprehensive information at just one AI model.
Yeah, this is a great question. So this is really what we try to achieve in a couple months' time. So as you can see from this image, we try to develop a technology that you can combine the OCT scan, and where you don't have to, first of all, you don't have to do MRI scan at all. We based on the fundus photo and also OCT, we can generate the ocular shape. But then the ocular shape is external. But then the challenge is that we also use a T1 image, as you can see here, MRI T1 image. The T1 image, you can perfectly see the ocular, the eyeball, like the wall, the shape, and also the wall, external and interior surface of the ocular wall. So with this information, and then also a unique solution in the OCT scan, you can reconstruct the whole eyeball, like with both information on the ocular shape, but also the internal changes. Thank you.
Yeah, thank you so much. Other questions? Yeah, Raja, please.
Thank you so much for the wonderful talk, Dr. He. When you talked about scaring patients, and patients are really scared about what would happen to their vision in the future. So when you mentioned about the OCT being generated by AI, by a combination of fundus photo and MRI, have you tried to look at specific changes in different layers of the OCT which can be predicted? Because I believe Brooks membrane and choriocapillaries are so crucial in terms of the visual outcomes in the future. So have you tried to look at, based on fundus photo and MRI, if you generate an OCT, which patient is likely to have Brooks membrane changes or choriocapillaries atrophy?
I agree with you. Because the idea of our whole idea is to develop a whole eye OCT. So with the OCT image, you can see all these structural changes, including the Bruch's membrane. But also you're able to see these tractional changes. Tractional, like this, which is the tractional change. Because I believe the retinal membrane and also the richest traction is more important in terms of like generating this high myopia damage, like schisis and all these problems.
Yeah, it's an important point you made, but I think as of now the epiretinal changes, we still have some surgeries to offer, but for the other changes we don't have any good treatment right now. So I just curious, so it can look at all the retinal layers.
Yeah,
as
all
well.
the retina layer, choroidal thickness as well. Yeah,
Thank you
everything.
so much.
Thank you.
Yeah, sure. Thank you so much,
you.
Professor He. And now I invite Professor Choko Ono Matsui, world-renowned expert in myopia, and she'll be talking on polarization-sensitive OCT imaging of scleral abnormalities in eyes with high myopia and dome-shaped macula.
Thank you, Raja, for your kind introduction. Sclera is mainly composed of collagen fibers, and causes of scleral fibers have been studied mainly histologically, while their precise in vivo arrangement remains a challenge. And polarization-sensitive OCT, or PSOCT, has the capability to visualize the density and orientation of fibers by measuring birefringence. Birefringence occurs when a material exhibits two different refractive indices depending on the polarization of light. And recent studies have shown complex collagen structures with PSOCT within a limited area around the optic nerve. So the purpose of this study that we used PSOCT to visualize the direction of scleral fibers in the wide area of posterior fundus of highly myopic eyes, whose sclera is easily visible. And we then investigated dome-shaped macula as a scleral pathology. And I show you an example of highly myopic eyes without pathologic myopia. In highly myopic eyes without pathologic myopia, only inner sclera is seen with OCT. And these are PSOCT images. The top panel shows birefringence, which means density of fibers. And green shows low density, and yellow shows high density. In highly myopic eyes, actually, mixture of different densities is seen. And the bottom figure shows the optic axis, which is the direction of fibers. And direction is color-coded, blue for horizontal, yellow for vertical, and pink-green for oblique. And in this horizontal image, you can see horizontal blue fibers running from the optic nerve toward the periphery. And in a vertical section, you can see horizontal fibers in the macula alongside oblique fibers upper and lower to the macula. And to our intuitive visualization, this is a streamlined image, and you can see circular arrangement of scleral fibers around the optic nerve, and then inner scleral fibers radially run to the periphery. So from when we see the scleral fibers from inside, there is a circular arrangement, and the inner scleral fibers run radially to this periphery. And then to observe the outer sclera, we examined eyes with pathologic myopia, because in this case, we can see the entire thickness of sclera. And this is, again, upper panel is birefringence, and lower panel is optic axis. And in density, in a vertical scan, you can see low density in the inner sclera and high density in the outer sclera. And the optic axis image, inner sclera is thinned, maybe because of the choroidal thinning, but the thin horizontal fibers run from the optic nerve toward the periphery. And so when we see the scleral fibers from outside the eye, scleral fibers run vertically. So this is an illustration. Around the optic nerve, we can see a circular arrangement of scleral fibers, and inner fibers run radially to the periphery, and outer retinal fibers run perpendicularly, almost vertically. And in eyes with pathologic myopia, inner scleral fibers get thinned, while outer scleral fibers remain almost unchanged. So let's dive to a dome-shaped macula. This is a horizontal dome, so you can see a dome-shaped macula only in vertical section. And this is PSOCT image, and this is vertical scan. In birefringence image, you can see a low density of scleral fiber is aggregated in the dome area. And in the optic axis image, you can see the aggregation of horizontally running inner scleral fibers, while outer scleral fibers do not seem affected much. And in a magnified image, you can see a dome-shaped elevation is composed of aggregation of inner scleral fibers alone, and the outer sclera is not thickened and rather compressed by the aggregation of inner fibers. So in dome-shaped macula, for unknown reasons, horizontally running inner fibers remain across the macula and aggregated there, while other inner scleral fibers thinned. So then bidirectional dome. In this case, both in horizontal and vertical images, you can see dome-shaped macula. And the images are similar. In birefringence, dome area is not a tight aggregation. It's a loose, low-density inner fibers aggregation. And in the optic axis image, you can see outside the macula, you can only see vertical outer scleral fibers. But in the dome, you can see a mixture of inner scleral, horizontal, and oblique fibers. So this is horizontal scan. So again, in bidirectional dome as well, inner scleral fibers strangely remain only across the macula, and it develops the dome-shaped elevation. So it is inner scleral fibers and not outer scleral fibers which cause irregularities of scleral curvature. So this is again a streamlined image to seen from the inside. You can see that in dome-shaped macula area, a mixture of inner scleral fibers are seen. And actually, in normal eyes, sometimes we see horizontal inner scleral fibers tend to remain in the macula. So macula is an important part for the vision. So sclera has some methods to protect the macula. So inner scleral fibers tend to remain. But this is a good thing, but it causes susceptibility to dome-shaped macula. So in summary, PSOCT clearly visualized the cause of scleral fibers in myopic eyes. In dome-shaped macula, its inner scleral fibers tend to aggregate, while outer fibers are not thickened. And when horizontal fibers predominantly aggregate, it causes horizontal dome. And when oblique fibers also aggregate, it causes bidirectional dome. And visualizing, and with usual OCT, we can only detect the thickness and the curvature of sclera. But visualizing scleral collagen fibers and visualize what is happening in the sclera could enhance comprehension of pathophysiology occurring in the sclera, like dome-shaped macula. And the next target is staphylomas and pachychoroid spectrum diseases. Thank you very much for your attention.
Kirko, I think this is very interesting in terms of understanding collagen, scleral collagen fiber direction. So has any people working on the pathology changes on the scleral, I mean in the highly myopia eye?
Yes.
So, so is it because of collagen, type of collagen? Because we understand collagen type 1 and collagen type 3, they're different. Collagen type 1 is for rigidity, and then collagen type 3 is for elastic. So would this pathology changes on the collagen type is associated with the direction of the fiber?
Yeah, actually at this point I didn't differentiate collagen 1 and collagen 2, but what we can say now is maybe inner sclera and outer sclera may have different roles physiologically and pathologically. And outer sclera is like a last resort to protect the eye from the eye rupture. So outer sclera remains until very, very severe conditions. But inner sclera may gather somewhere and may thin its other places. So it causes eventually irregularity. So I think it may be the inner sclera which causes staphyloma edge, dome-shaped macula, such elevation. So yeah, the role may be different. But collagen type, I haven't checked it yet. So the correlation between orientation and quality of collagen types would be very important topics. And in highly myopic eyes, it's inner sclera, which thins, and outer sclera is almost unaffected.
Okay, thank you.
Yeah, thank you.
Thank you, Professor Kyoko. Can I ask a question? This is a phenomenal work. Congratulations and always very inspiring.
Thank you.
I found that all these imaging, do you have some index or quantifiable measurement so that we can interpret more easily? Otherwise, by doing the pattern, sometimes it may be difficult
Yes.
to interpret.
Yeah, thank you very much for your great question. Yes, quantification is really necessary. And we can now measure the thickness of inner sclera and outer sclera and check a correlation with myopic degree. And, density is a little difficult to measure, but quantification, I think, is a key. And we now have many treatments like red light therapy, and we also measure the scleral quality, direction, and density before and after red light therapy. And if this therapy affects the scleral quality, I think the effect may be permanent. So quantification is a key. Thank you.
Great
One.
talk. A couple of questions. First one is the PSOCT. Can it also be used in low myopes to detect the sclera?
Yes, still to visualize the sclera, we need to see the sclera with conventional OCT. So at this point, for example, pachychoroid spectrum diseases in emmetropic eyes, hyperopic eyes, it's impossible, not yet. But if the resolution and penetration improves in the future, it may become possible.
The other question is, do you think you will see such differences even in the anterior region of the sclera if you believe in the global expansion model of the eye?
Yes, yes, it's possible. But to visualize anterior sclera, we need a different device. So our device is not equipped with such quality. But that is an important point. Thank you so much.
If I can have one last question. Once again, excellent presentation. You had mentioned about the density being less in the horizontal layers, fibers, and the subfoveal, but still the sclera was thicker compared to the extraocular sclera. So did you also see the number of posterior ciliary arteries penetrating the sclera? Was it less or more in the thicker outer sclera versus thinner outer sclera?
Yeah, that's a great point. Thank you so much. Actually, with this device, we also found that at the penetration site of ciliary arteries, there are circular arrangement of sclera because the penetration site is fragile. And in highly myopic eyes with expansion of globe, the emissaries enlarge, but eyes almost never spontaneously rupture. So like the optic nerve area, a circular arrangement there. So I think this can resist to the axial eye expansion and maybe scleral thickness. But we haven't examined that, but that is a great point.
Thank you so much, Dr. Matsui. We'll now move on to the next speaker, Dr. Jason Yam, on pathogenesis of myopic choroidal neovascularization.
Dear colleagues, thank you, Chairs, Professor Kyoko, and the chairs for the very kind invitation for me to speak on the topic pathogenesis of myopic choroidal neovascularizations. So pathological myopia is a leading cause of visual impairment, and myopic CNV is one of the most common complications in pathological myopia, causing the central visual loss. And Professor Kyoko Onomatsui has led a group to evolve the meta-pathological myopia classification, from the myopia maculopathy from no lesion to tessellated fundus to diffuse chorioretinal atrophy, patchy chorioretinal atrophy, and macular atrophy. And also there's a plus lesion including the lacunar cracks, the choroidal neovascularization and field spots, and also staphyloma is another very important feature for the pathological myopia. In the ATN classification, the neovascular myopic maculopathy is mainly referred to the myopic CNV. And myopia CMV prevalence occur in pathological myopia is about 5% in the United States and 11.3% in Japan. And if we have one eye myopia CMV, and the risk of fellow eye having the myopia CMV is about 35% within 8 years. And if untreated properly, the irreversible severe visual loss will occur in 5 to 10 years. There are 3 main stages of myopia CMV, from active with some subretinal hemorrhages and to the scarring stage, that is the field spot, and also the atrophic CMV, all are associated with vision impairment. Myopia CMV diagnosis could be by symptoms, by fundoscopy, fluorescent angiography, OCT, and OCTA. Timely and appropriate management of the myopia CMV is very crucial because, and also unraveling the etiology and predisposing factor for the myopia CMV is also important to develop precautious measure and proposing treatment option. Mechanical hemodynamic heterodegenerative theories have been proposed. However, the precise pathogenesis of myopia CMV remain unclear. We have conducted a meta-analysis of the literature to look into the pathogenesis of the myopia CMV, and today I wish to share some of the results based on this meta-analysis with you all. And so we include 50 studies with a total of 14,000 eyes, including about 35% with myopia CMV, and the other 16.5% cases with no myopia CMV as a control. So among these case and control, we evaluate the outcome, including different outcome, including the structural factors, the hemodynamic changes in choroidal circulation, the genetic factors, and the systematic predisposing factors. The lacunar crest are sharply outlined defects of the retinal pigment epithelium, branch membrane, choriocapillaris complex with normal overlying neurosensory retina. And in fact, myopia CMV had a higher proportion. The odd ratio is 2.8 with the lacunar crest. And the patchy chorioretinal atrophy is a complete atrophy of the RPE and choriocapillaries, appearing as a grayish white, well-defined lesion. And the myopia CMV again had a higher proportion of the patchy chorioretinal atrophy with the OR 3.5. For the posterior staphylomas, again, the average height of the posterior staphylomas for those with myopia CMV are much greater. The mean difference is 82 micron higher comparing to those eyes without myopia CMV. In fact, the mechanical factor predisposing these pathogenesis, the lacunar crest can trigger the wound healing mechanism leading to the myopia CMV, and also it also creates a space allowing for the neovascularization, and also the fibroblasts and inflammatory cell can migrate from the choroid to the subretinal space. For the patchy chorioretinal atrophy, also there is at the edge there can be a damage that may trigger the CMV, and also the posterior staphyloma is a key for the choroidal thinning. And the choroidal thinning will elaborate more on the pathogenesis. And the hemodynamic changes, there's 2 factors that can contribute to this the pathogenesis. One is the choroidal filling delay. 2 studies have found a higher resistivity index and decreased blood flow in the posterior ciliary artery in eyes with myopia CMV compared to the non-CMV eyes. And the choroidal filling delay was a predisposing factor with the odd ratio 42 comparing to the control group. And another very key important factor is the choroidal thinning. And the choroidal thickness in the myopia CMV eyes is significantly thinner than the control group, with a mean difference 50 micron thinner. And also the perforating scleral vessel could be also related. A field report has mentioned that PSV were detected in area of myopia CMV in over 70% of the subject, and 2 studies has reported that PSV and myopia CMV can be continuous through the defect of the branch membrane, suggesting that myopia CMV can originate from a deeply situated scleral vessel. And for those cases which with PSV can show a higher rate of activity and need a poorer response to the anti-VEGF injection. from that. Here show different relationship between the PSV and also the CMV. Some are fitting into the CMV, some are connecting, and some are passing underneath the CMV. So when there is a choroidal filling delay, in fact it can cause outer retinal hypoxia, and which can induce the VGF upregulation causing the CMV formation. And also the choroidal watershed zone is one of the factor causing the choroidal filling delay, and again these are also leading to the hypoxia causing the myopic CMV. Choroidal thinning is also one of the potential cause of causing the retinal hypoxia, which induce the VGF secretion and also the CMV formation. And the previous mechanical lesion, such as the lacrimal crack and also the posterior staphylomas, are also causes for the choroidal thinning, which induce all these hypoxia mechanism. And the genetic factor is also related, has been identified that the CFI gene in the SNPs can also be linked to the myopic CMV in Caucasian. Another COL8A1 gene is also associated with the myopic CMV in Caucasian. And the VGF gene is also associated with the CMV size in Japanese. And some non-coding RNA genes has been also been associated with the CMV development while different signaling pathway. The systematic predisposing factors, including the VGF and interleukin-8 and also other inflammatory factors, has been reported to be higher in the concentration and in the level in the aqueous humor in those myopic CMV eyes comparing to those eyes with high myopia but no CMV. These again can also be related to the theory for the mechanical stretching theory, because the elevated level of the VGF may trigger proliferation of the vascular endothelial cells and growth factors, and which induce the CMV. And also the hypoxia can also leading to these VGF dysregulation. And the VGF overproduction can lead to the CMV. So in summary, in our meta-analysis, in a group of patient with a myopic CMV and a group of patient with highly myopia without myopic CMV, what this meta-analysis from the literature found is there's a higher ratio of the lacrimal cracks and patchy chorioretinal atrophy, and the posterior staphyloma in those myopic CMV are greater height, and there is a thinner choroidal thickness, and also there is a higher level of the VGF and interleukin-8 in the aqueous humor, and also there is other structural predisposing lesion, including the hemodynamic factors, gene polymorphism, and systematic factors were also involved in the pathogenesis of the myopic CMV. So I would like to once again invite you all to the coming third Congress of Asia Pacific Strabismus and Pediatric Ophthalmology Society, which will be held on June 29 to July 1st in the Brisbane Convention Center in the Brisbane, inviting you all to join this conference, and also looking very much warmest invitation and welcome to you all to attend the APAO 2026, which will be held in Hong Kong in February 5th to 8th. It will be a time which is very near Chinese New Year, the Lunar New Year. When you come to Hong Kong, you will have a full atmosphere of the very festival season, and I promise you an unforgettable stay in Hong Kong. We will try our best to host you, everyone, to come to Hong Kong. Thank you very much.
Jason, thank you so much. Any questions? Jason, it is a very interesting. Your theory is highly structured. And I'm also thinking about inflammation, the role of inflammation, as you showed IL-8. And some lesions like cracks and patchy atrophy sometimes originated from peak punctured inner choroiditis. So I think maybe among myopic CNV, some kind of peak CNV may be involved. So maybe the role of inflammation may be higher than we thought. Have you experienced any patients with peak OCT, peak CNV?
I I have very little experience, but I'm looking forward to learn from Kyoko, Professor Kyoko. And in fact, for these cases, especially, I think the retinal, the choroidal thinning, especially I understand they are using now the red light therapy for all these choroidal circulation. Do you feel that it is really hitting on the choroidal thinning mechanism so that it can prevent the myopia CNV in these cases?
Yeah, excuse me. Could you say it once again? Sorry.
So because we understand that there is an inflammatory marker, there is choroidal circulation markers, there is some structural markers. So the hypoxia and also the inflammatory is also one of the key drive for all these mechanisms. I'm just asking your opinion on the using of some circulatory treatment that can improve the circulation, including the red light therapy. Is it helping to translate or prevent all these damage?
Yeah, that would also be possible. And actually, we had a research on highly myopic adults to see if the red light therapy on adults can increase choroidal thickness. Because in addition to neovascularization, for atrophy, we don't have any treatments right now. So if we can maintain choroidal thickness, I think it would be beneficial for them.
Thank you. Thank you.
Very nice presentation.
One question, please.
Yeah.
Sir, how do you follow these patients? How do you treat or manage this kind of patients?
For the myopia CNV?
Yeah.
Of course, the treatment, I have to declare that I'm not a vitreoretinal surgeon. I'm a pediatric ophthalmologist, but we have done a meta-analysis. For all these treatment cases, I will be managing this with my vitreoretinal colleague, which will do the VGF injection for all these myopia CNV.
Yeah, once again, a very nice presentation on the meta-analysis of various risk factors for myopic CNVM. I just wanted to check if you also looked at the recurrence of myopic CNVM. The recurrence rates of myopic CNVM, because traditionally we know that myopic CNVMs require less number of injections compared to, let's say, macular degeneration.
Right.
However, in our study we have seen about 30% recurrence rate, while in the first and second year there may not be as much recurrence as macular degeneration, but over a period of time almost 30% had recurrence, and some of these eyes do really bad. So was seeing if you also looked in your meta-analysis predictions for recurrent CNV.
Yes, it's very important that for those recurrence and the factor inducing all this recurrence is important. But in our study, because it's a meta-analysis, we're just looking into those who are diagnosed with the CNV and those without CNV, and then we look into their underlying differences in terms of the number of those who are lacrocrat, number of those of the other features, and then to analyze. We don't have the data to analyze, allowing us to analyze the recurrence rate. It is very unfortunately, but all these recurrence cases and the factor is also very important. Thank you very much.
So thank you, Jason. And our next speaker is Dr. Pavan Berkjala, and he is going to talk about. Yeah, he's going to talk about personalized myopia control strategies.
A very good afternoon, everyone. So before the myope gets to the hands of retina specialist, can we do something? I think that's where I will concentrate on. No commercial interest in relation to this talk especially, but I have a couple of patents filed and we do a lot of multiple clinical trials in relation to myopia. Now this slide should explain it all. Why is the need for the personalized myopia care? All myopes look same, but I think they are a little different, and one size does not fit all. And we all agree that there is no universal protocol to treat the myopia, child with myopia. And there are multiple ways, but I think the single agenda worldwide is to ensure the eyeball does not grow any further. So I'll try to justify why personalized myopia strategy is important, and I will take 5 points. The first point is all myopes are not necessarily the axial myopes. Just because we see somebody with -7 does not mean this is an axial myopia, and does not mean we should start some treatment. It could be refractive myopia, cornea is just steep, or it could be keratoconus as well. At times the lens is anteriorly shifted and you see more myopia. In that cases as well, there is no need for us to trigger for unnecessary treatment. And at times it's the refractive index change as well. We do also see a lot of pseudomyopes. Now this is a child 10 year and -7 myopia. And if I just present this information, you would think that, okay, let's start some sort of myopia control treatment. But if I show you the axial length, it's only 22.7 millimeters. And you look at the cornea, it's not too steep as well. And then we put the cyclopentolate, and you see that it's actually +1. So clearly, there's no point for us to be more aggressive unless you really know this is a case of axial myopia. The point number 2 is to say that not everybody is progressing. Again, let's take the same example of -7. Again, there's no need for us to trigger for some myopia control treatment unless there is an obvious myopia progression. And talking about the Indian context, we see that about 17 to 20% of them have rapid myopia progression, which means 1 out of 5 individuals with myopia needs these treatment options. On the left, you see 12 year, both of them are actually 12 years. And if you look at the case 1, it's -7. Previous prescription, which is 3-year-old, is also -7. Versus case 2, if you see in the last 1 year, it jumped by 1 diopter. So you might want to concentrate case 2, but not the case 1. Point number 3, the mechanisms or the risk factors for myopia are many, and they revolve around near work, defocus in the periphery. Now we talk about contrast in the periphery, light, again dopamine release, or maybe staying away from the near work, or it could be the spectral composition of light or the uniform dioptric field if you are in an outdoor setting. So the various theories, again there is no single theory to say that, okay, there's one treatment and I will do that and it will be controlling the progression of myopia. The risk factors are many, and this is much more latest, I think published only a couple of days ago, showing the theories for why atropine could be working. Again, we do not have a clear answer for where the site of action is, but it could be acting at the multiple levels, and these are all the proposed hypotheses. Given that myopia is multifactorial, yes, we do have multiple solutions. But point to note is that the site of action is very different. Bifocals act at the level of accommodation, defocus lenses act at the level of the peripheral retina, and now we have dot technology working at the level of contrast, and we have seen the previous slide, atropine working at the receptor level. So the site of action is very different. Unless you play like a chess, which means you are picking your treatment very wisely, you will not be able to see desirable outcomes. So one thing that I want to indicate is there is evidence to say that all these treatment strategies actually work. This is a living systematic review that we published a year ago, which indicates that high dose atropine, yes, great, fantastic, but it has its own complications. We do not know the long-term complications that the child may have. Orthokeratology, again, nighttime wear. So everything, either there is a cost or there are complications, or we do not know what really works or what really benefits on a long run. So from the optical standpoint, I think there are multiple myopia control options that are made available in multiple countries now, all the way from bifocal to the various peripheral defocus spectacles to the very old orthokeratology. Now I want to highlight the advantages that we get with the optical myopia control options. Number one, you want to correct myopia anyway. You don't want to leave them uncorrected, so you want to prescribe some sort of optical element. If you can give control also in the same mode, why not? So it's like you do the correction, you also get control, and the compliance is much better. Unlike the eye drops where the parent has to instill, now you're wearing anyway to see things clearly, so the compliance is much more better with the optical strategies. And the emotional stress that the parents or the child has to go with the external agent versus something that they have to wear, I think is much more minimal. Complications, again, less or nil. The only worry that we have right now is the cost. That's a bit of challenge, but the clinical trials that we are running, I'm confident that the cost is going to come down. Now, with keeping that in view, the 5 points to say that, okay, now we want to do a personalized myopia management, where do you start and where do you stop? So we sort of came up with an impact myopia guidelines published in Indian Journal of Ophthalmology in 2021, well 2022, involving both the ophthalmologist and the optometrist. So we said impact is an acronym. If you remember impact, the 6-step rule which can help you to start and stop the treatment. The first one, like I've indicated, is I stands for identify a true axial myope. Eliminate all the cases of refractive or pseudomyopia. Given that myopia is multifactorial, map the risk factors. I mean, as simple as asking them what's their lifestyle, indoor, outdoor. If you have a retinoscope, you can really look at the accommodation, you can look at the phoria, because that will help you what treatment you want to give. Pick a progressive myope. P stands for there's no point just because there's myope, they don't have to be progressive myopes. Unless you have a progressive myopia, there is no point for us to trigger for some unnecessary treatment, as I have discussed already on the 2 cases. Given that we have multiple options, there's no point in shooting in the dark. Otherwise, you will not get desired outcomes. So I think when you look at the risk factors, at times mere lifestyle modifications will give you fantastic outcomes. At times you want to go with the bifocal. When there is esophoria, greater lag, bifocal works great. When you know that there is relative peripheral hypermetropia, the defocus treatment actually works great. I will also quote one of the papers from Hong Kong that indicates that if somebody has relative peripheral myopia, then these DIMS lenses did not show a fantastic outcome compared to the ones who already had a specific pattern. So you might want to really look at that. Again, if you have a retinoscope, if you go a bit off, you will be able to know if it is relative peripheral hypermetropia or myopia. So we say that in myopia management, you want to monitor much more closely, not in every year, but 4 to 6 monthly. If you have a non-contact biometer like LensStar, Royal Master, any of the biometers, you will be able to pick these changes much more easily, even in the period of 4 months. If you're looking at rapid myopia progression, the resolution of these devices is only 10 microns. But if there is a rapid myopia progression, you're going to pick about 100 microns change, meaning 0.1 millimeter. One treatment does not work in 6 months' time, you might want to really think about combination myopia control treatment. Usually we follow monotherapy first. One does not work. There's a rapid myopia progression. Even with mono treatment, we try to combine the pharmacological treatment strategy. Another million-dollar question again is, when do you really stop treatment? The multiple debates about this, there is no single answer, but I think late teenage is the key word. Just because you see a good myopia control at 8 years or 9 years with 1 year treatment, I don't think you want to take them off, given the rebound effect that you're going to see. Now, refractive surgeons consider operating only at a late teenage or 20 plus years, keeping in view of the stability of the eye or the plasticity of the eye. Same needs to be applied here as well, and you might want to taper if you're using atropine. So I will quickly go through 4 cases. The first one is a young adult having a myopia progression, actually came to us for undergoing refractive surgery, but given that there is myopia progression, the individual was referred to the myopia center. And we've seen in the myopia center in 2021, right eye pretty much stable for a good decade, but left eye kept on progressing. And at the time we have seen, it was already minus 9.5. We're talking about high myopia. What do we do? So the axial length also sort of correlates 29 millimeters in the left eye. So we looked at the peripheral refraction. It was a little different in the left eye. When I say different, it was relative peripheral hypermetropia. Now for that minus 9 at that time, we had multifocal contact lens, and anyway there is anisometropia. So keeping that in view, we went on to give myopia control contact lens in the left eye, and you see that the power did not change. I've seen the patient in 2024 March as well, and the axial length was pretty much stable, and we could control the progression. Now second one, 13-year-old child, and age of onset was 5 years. Points to note are the last 3. There is relative peripheral myopia. The moment I saw relative peripheral myopia, I sort of eliminated the use of defocus spectacles there or the contact lens. Then I said, okay, what's the lag? It's 0.75. There is esophoria for near. I said, all right, let me go with the bifocal spectacle. Now, bifocal, if you see this in 4 months' time before treatment, in just 4 months, the eyeball length changed by 0.18 millimeter in the right eye. In 1 year, the changes were only 0.12. So whatever you could see in 4 months because of the intervention, And our good thing was we could see or delay that stretch. Same is the case in left eye. Whatever we saw in 4 months, now it went on to show in 13 months. So we also see that, okay, is it rebound happening only with the atropine? No, the rebound is also seen in optical myopia control treatment options. I will show you with this case. There's obvious myopia progression, and we started them on excellent depth of focus contact lens, and that's the changes 0.08 millimeter and 0.02. Only very happy. Patient did not use contact lens for 4 months. You see that change. Just 4 months, it went to 0.14 millimeter. We said, all right, we use MyoSmart now. Patient did not want to use contact lens, so we used the DIMS technology. We gave the lens, and then we could get the myopia back in control. So I think that this highlights 2 points. Number one, even with optical strategy, you see rebound. And number two, close monitoring will help you to really get things in control. This is again a high myop minus 19 diopters of myopia. Is there an evidence? We said, okay, we cannot leave that individual without any treatment. So this is minus 19, and we gave a partial correction. Whatever we had contact lens, we gave in myopia control contact lens until I think minus 12, and the remainder we put them on the spectacle single vision, and you see that changes are pretty much in control. So why personalized myopia control treatment? I think one size does not fit all. Clearly not everybody is an axial myope. Given that myopia is multifactorial, there are multiple solutions out there with site of action being very different. I think if you shoot in the dark, it may hit, but it may be a miss as well. So I think one case at a time. With this, I thank you for your attention.
Thanks so much, Pawan, for that wonderful presentation. The first case out of the 4 cases was very interesting. One eye was progressing so much. The genetics is the same, environmental factors, lifestyle, it's all the same. But one eye was not progressing, the other eye progressed so much, and obviously I assume there's no history of any surgery or anything.
No,
so what do you think could be the reasons for that discrepancy?
I mean, usually in case of anisometropia, there is some evidence to say the role of posture of the child while the near work to trigger for greater changes in one eye compared to the other. Maybe there is a different posture for one eye. Now, the second point is in terms of optics as well, we saw that the pattern in the periphery, the refraction, was clearly hyperopic only in the left eye, whereas it was not the case in the right eye, and that could be the reason for why. Now, what triggers the shape of the eyeball, why it has to be very different in one eye, I think is something that we clearly do not know.
So my bigger question is, I mean, this is not a usual case. It's rare to have this kind of so much asymmetry, but overall, are we missing some important factor in terms of myopia understanding, which we still have to discover?
Totally. I think we clearly do not know the markers. Dr. Yam has clearly indicated what could be the triggering factor, and we all rely on the lattice to be some sort of a start point. But before lattice, what could be happening? One of the other cases that we have seen, again, I'm relating largely this to the peripheral defocus. In 5 patients we have seen in the myopia center, whenever there is a lattice in that specific location, we have noted there is significant magnitude of the hypermetropia in that meridian, whereas it's not seen in the other locations. In India, we also see nasotemporal asymmetry in the PR pattern, and in these 5 courses we saw that. So again, the puzzle is not solved, lot to be looked at, but there are some dots that we could connect.
We should move on. Thank you so much. Our last speaker is Dr. Takahashi. Dr. Takahashi is going to specifically talk about myopia, translational maculopathy.
Okay, thank you for having me. I'm Tomonari Takahashi from the Institute of Science Tokyo. Today I'm going to talk about paravascular abnormalities in myopic traction maculopathy. So myopic traction maculopathy, MTM, is a schisis-like thickening of the retina in eyes with high myopia. MTM includes lamellar or full-thickness macular hole and foveal retinal detachment. It is estimated to affect 9 to 34% of highly myopic eyes with posterior staphyloma. Pars plana vitrectomy is useful for resolving it. OCT is essential to diagnose MTM. The key factor of MTM is tractional forces. So what is the tractional forces? There are some reports about it. These 5, vitreomacular traction, vitreous cortex, retinal vessels, internal limiting membrane, posterior staphyloma, are considered to be tractional forces. Multifactor of these could make the MTM condition. Next, I'm going to talk about internal limiting membrane. So internal limiting membrane, ILM, is considered to be a main cause of traction. ILM is the basement membrane at the vitreoretinal interface, and it is consisted of type 4 collagen, laminin, and fibronectin. ILM is thicker in the fovea than in optic disc and peripheral area. The rigidity increases with age. So how can we decrease the tractional forces? Vitrectomy with ILM peel has been shown to result in anatomic resolution of MTM and to improve visual acuity. However, there is a big complication, postoperative macular hole. In 2012, Dr. Ho and Dr. Shimada invented fovea-sparing ILM peeling. Recently, FCIP technique is widely used for the MTM surgery. So today, I especially focus on retinal vessels. As for examination, we use retromode imaging. Retromode scanning laser ophthalmoscopy imaging uses an infrared scanning laser ophthalmoscope to capture a pseudo three-dimensional image of ocular fundus. Past studies revealed that there are 2 findings using retromode imaging, striae and fingerprint. Striae is like this picture. Striae is the linear lines that run radially from the macula. This is fingerprint. Fingerprints are consisting of dots and striae that have no fixed direction. This is the new findings, dots. Dots are granular findings near the macula. This is parabascular striae. There are straight lines that cross the retinal vessels like fishbone. We have searched total 56 eyes of MTM, 28 eyes, that half of the participants had parabascular striae. There were no significant difference between the retinal schisis type and retromode image findings. The retromode findings does not simply show the schisis structure. However, retromode findings, especially the difference of macular striae and dots are near the macula, could be the great implication for surgical intervention. The difference of 2 could be occurred due to the Henle fibers learning. Dream OCT is the product of Intellite and the latest OCT machine. It is swept source OCT and the depth is 12 millimeter. We could get clear image of retina and vitreous. In this case, vitreous humor is tightly attached with a retinal vessel. There is no retinal schisis, but tight vitreous adhesion could be the main reason of retinal schisis. This is very important case. At a glance, this is a quite normal MTM case, and we think that ILM traction is the main cause of this MTM. However, when we see in detail, there is a vitreous adhesion to the retinal vessel. Vitreous humor attached hard to the retinal vessel, and that could lead to parabascular abnormalities and retinal schisis. So next, I will focus on parabascular abnormalities, PBAs. Some types of abnormalities have been reported, like parabascular microfolds, parabascular cysts, and parabascular ramular holes, as shown in this picture. Parabascular microfold is a projection of retinal vessels toward the vitreous cavity. Parabascular cyst is a spindle-shaped dark areas or fissure-like lesion adjacent to retinal vessels. And PBAs is the cause of foveal schisis. So there are some reports about parabascular abnormalities. PBAs are detected in 82.9% of highly myopic eyes. Patients with PBAs are older, more myopic, and longer axial lengths. Parabascular holes are detected in 26.3% of the highly myopic eyes. The incidence of parabascular ramular holes are from 14% to 31.4%. So what is the cause of PBAs? First, parabascular microfolds, parabascular microholes occur with aging, frequently accompanied by the vitreoretinal adhesion at the retinal vessels. Second, parabascular cystoid space appears around the parabascular microfolds. Third, palabascular lamellar holes develop as the inner wall of palabascular cyst is removed by the vitreoretinal folds, or palabascular retinoschisis occurs with continuous vitreoretinal adhesion. So when we do vitreoretinal surgeries, we should care PBAs. From here, I will show you some representative cases of PBAs. This case is 64 years male with 32.55 millimeter axial length. Using ultrawide field OCT, we could detect vitreous adhesion to palabascular area. Vitreous humor attached both sides of the vessels like bleach. We could detect palabascular lamellar hole and microfolds. Vitreoretinal surgery was conducted with complete island peeling and no tamponade. Day 1 after the surgery, we could not detect any complications. At day 7 after the surgery, palabascular hole was occurred. We could not know when this complication happened because the image was not clear due to postoperative inflammation and desmofold. With retromold imaging, it is easy to detect palabascular hole. During the reoperation, there was no ILM around the hole. We enlarged the PBD using forceps and tamponade with C3 F8. In this case, weird vitreous adhesion is probably the main cause of postoperative palabascular hole. Second case is 66 years old female with 29.46 millimeter axial length. We could detect posterior staphyloma with normal color from this photo. We could not evaluate PBAs correctly because we did not take the wide field OCT preoperatively. There was outer retinoschisis and outer retinal defect region. We conducted vitreoretinal surgery with complete island peeling and non-tamponade. At day 3 after the surgery, we could detect tiny palabascular hole. 1 month after the surgery, retinal detachment occurred around the palabascular hole region. Using retromold imaging, palabascular hole and retinal detachment region is easy to detect. In the reoperation, there was no ILM around the hole. We enlarged the ILM peeling area and did tamponade with SF6. Third case is 66 years old female with 27.53 millimeter axial length. At the first presentation, this patient has huge retinal detachment region. This case is also easy to detect posterior staphyloma, and retinal detachment is easy to detect using retromold imaging. During the surgery, vitreous adhesion around the palabascular lamellar hole was so hard, we used forceps for removing that and did tamponade with air. Contrary to previous 2 cases, third case was severe, but there was no complication. So when we face the postoperative retinal detachment due to palabascular abnormalities, what can we do? There are 4 choices: additional island peeling, a laser around the brakes, inverted island flap, and autologous island plantation. Retinal plaques in the posterior pole usually do not enlarge if island is peeled. However, high myopia cases, especially high myopia with posterior staphyloma, there can be tractional forces because of the distorted eye shape. So what should we do in the first surgery? My answer is fluid air exchange. Normally, MTM could be treated without tamponade if the traction is adequately removed by surgery. And also, some papers reported that as for visual improvement in a long-term vitrectomy without tamponade is better than with tamponade. The eyes with palabascular abnormalities also has other vitreous adhesive lesion. And when we do vitreoretinal surgery for MTM, there is no case without postoperative palabascular hole. This phenomenon is similar to Schrodinger's cat. Of course, for the cases with deep posterior staphyloma, fluid air exchange cannot be effective. However, decreasing the risk is very important thing. So this is conclusion. Retromold imaging is useful for evaluating palabascular holes. Using ultrawide field OCT is necessary for grasping the details of the patient condition near the vascular region. Island peeling should cross the arcade vessels. Fluid air exchange is necessary for preventing retinal detachment progress. Thank you so much.
Thank you so much. This is really interesting talk. So in your understanding, in particular, this retinoschisis, just trying to learn from you, how many proportion of these cases is secondary to traction and how many secondary to, I mean, the porting fidget, just like the usual, I mean, the retina scene.
So you mean,
I mean,
how many percentage of
How
the
many percentage of
retinal
the retinal
schisis
schisis is because of traction?
Oh,
and
so
how many
I'm
percentage
sorry,
because of
I don't
the
have the
histological features?
yes, I don't have the precise numbers, but there are yes, many factors are affected to the retinal schisis conditions, and most of the cases just only peeling of the ILM is the resolving the conditions. So and it is very difficult to grasp the conditions clearly because the vitreous adhesion and the ILM traction, both of those are the causes the MTM condition. So I'm so sorry, I can't answer you the precise number of the percentage.
Thank you.
Are there any other questions?
So, thank you for the just like surgical meeting. But yeah, I'm sorry that that's a surgical question. So I think regular ERM surgery, we remove the ILM just before the arcade vessels. But I think we should remain the ILM very close to the vessels. So I do surgery for this kind of patient with ILM removal. I remain one distance or half distance of ILM from the vessels. So we need to change the nuclear.
Yes.
How do you think?
Yes, thank you for the comment. So I think so too, but for the myopic traction maculopathy cases, we should peel the ILM across the retinal vessel for resolving the tractional forces. And in some cases, I just show you some dream OCT cases. Those cases, vitreous traction to the retinal vessel is very hard. For those cases, we don't do the aspire the vitreous humor and pulling out is very dangerous because that can cause the palavascular holes, postoperative palavascular holes. For those cases, we think that the ILM peeling is first we should do. That can peel the gentry, the vitreous, decrease the vitreous traction from the retinal vessels. This is my proposal.
Actually, my question was for Dr. Pavan, but we quickly switched to the second presentation, so I would now. So, first thing I want to ask is in the axial myopia progression cases, you are taking both the increase in the axial length and the refractive error as well together to label it as a progression, and then we start some treatment, or either of the two?
Very good question. To label them as axial myope, we will definitely need axial length to say that, let's say there's -4. Axial length cannot be 22 millimeters. So you approximately have an estimate of, okay, it could be 25.5. That's a first step. Now you started them on treatment. Now the main parameter would be the change in axial length, because axial length changes you will see first, and then only later you will see the changes in refraction. Now you don't have to wait to see the changes in the refractive error also. If let's say at times, because myopes tend to have better depth of focus, they will be having 0.5 change in the refractive error, but they don't accept. So there is no point for us to wait if there is already more than 0.15 millimeter. I'm talking about the Indian context.
All right. One more question I had about the age criteria. Like at our hospital, we are taking 5-6 years as the cutoff to either give the defocus glasses or to start LD. So this is the age limit that we should be following, or we can start
I
it
think
early?
based on multiple clinical trials as well, it start with 5+ years, and even at LVP we tend to do the same. Beyond 5. But again, there will be change in the plan on a case-to-case basis. Let's say there is axial myopia and then child is only 4 years, I'm sure there is treatment given at that stage as well.
All right. So that would be a defocus class because
Again, to start with, you want to stick to the optical management,
yes.
unless there is high astigmatism or maybe high myopia, when you don't have options in the optical.
Okay. All right. Thank you.
Thank you so much. I think in the interest of time, we're going to close the section so that our participants can attend these Asia Pacific awardee sections. Thank you so much for all the speaker and the audience, and please enjoy the rest of the day. Thank you so much. And also, I would like
Thank
to
you.
thank our co-moderator as well.
Thank you so much.
Thank you so much.